Mr. Chairman, thank you very much for the introduction. Ladies and gentlemen, it's my greatest pleasure having the opportunity to speak here today. Now, something totally different. We are going to talk about ovarian stimulation. And I was asked to speak about new developments for ovarian stimulation. Now, the field is huge, so arbitrarily, I picked a couple of topics which I hope you will find of interest. Now, firstly, I'd like to talk about the end of a controversy regarding the efficacy of different protocols that we use for ovarian stimulation. Then I'd like to touch upon a very important topic, and that is inducing final oocyte maturation with agonists instead of HCG, and where that is still a controversy. And then finally, I'd like to share with you some deeper understanding and further insight that we gained from the largest phase 3 trial program that has ever been done on ovarian stimulation, and this is on corifoliotropin, and then eventually I'll give you 2 or 3 points for thought at the end of the presentation. So let's have a look at the German IVF registry, latest data from 2010. What we see here in terms of protocol usage is a prevailing of a long agonist and approximately 38% antagonist. Now, these figures have dramatically increased in the last years, but still long agonist is predominantly used. If we look at the pregnancy rate in the registry report, you see it is more or less stable across protocols, yet for the long agonist is slightly better. However, bear in mind that these are purely observational data, and that such data can be enormously biased by, for example, patient selection. And we did a study published 2005 in Human Reproduction where we showed that if a patient had failed on the first, second, or third IVF cycle, she was more likely to be put on an antagonist protocol instead of a long agonist. So the primary choice was long agonist, and only if a failure occurred, physicians switched. And this is depicted here. And moreover, what we show on a huge database, this is more than 270,000 cycles, that physicians chose to use an antagonist protocol more often in older patients. Now, both factors constitute, of course, negative selection, and this is why such observational data cannot be taken as any proof of efficacy. So here we need the randomized controlled trials. Now, we did have some randomized controlled trials which really initially set a controversy which has been going on for 13 years about what ovarian stimulation protocol would yield most pregnancies. Now, let's have a look. If we go back in time, we see in 1999 the antagonists were licensed in Europe, and in 2001 the first meta-analysis was out. The conclusion was there's no difference in clinical pregnancy rate, but this meta-analysis was not well conceived. There were retrospective studies, abstracts in there. It was only in 2002 here that a Cochrane review, the holy grail of evidence-based medicine, concluded that there is a lower clinical pregnancy rate with antagonists. And this publication, of course, caused major concern among physicians that by using antagonists, they would hamper the chance of the patients to get pregnant. Now, in 2004, there was a meta-analysis from a colleague from Canada, Salim Daya. The conclusion was no difference in clinical pregnancy rate. In 2006, there was an update of the initial Cochrane from 2002. Again, the conclusion was lower ongoing pregnancy and live birth rate. And then there was also in 2006 another meta-analysis together with some people from Greece. The conclusion was no difference in live birth rate. Now, ladies and gentlemen, how, as a physician or embryologist, can you not be confused with all these publications? But the truth is, if we go back to 2002, and when we reanalyzed the data from the 5 phase 3 trials that formed the basis for this initial Cochrane publication, for the denominator per randomized patient and for the numerator live birth rate, the conclusion was that at that stage, a difference in live birth rate has not been present. in terms of statistics. The truth, ladies and gentlemen, is that in 2006, we did an analysis per randomized patient on the numerator live birth. And the truth is, no difference in live birth weight between agonist and antagonist stimulation. And I please ask you to have a look at the odds ratio, which is 0.86. Bear this in mind just for a second, please. Now, some people say we should look only at the phase 3 trial populations because these are the studies with the highest quality. And we initially had 5 phase 3 trials, but now we have a 6th one, which was conducted in China, and is down here. These data are not fully published yet, but the origin of the data is that the company wanted to license antagonists in China, and the licensing authority said, no, you got to redo a phase 3 efficacy safety trial in our Chinese population, which might be different from the Americans or the Europeans. So you see the outcome of that study, which is perfectly on the intercept here. And again, of course, the conclusion is, if we look at all the available phase 3 trial data, there's no difference in live birth weight between the analogs. And finally, last year in May, Wheely, the publisher of Cochrane, made the following press statement. And it said, with new information available, authors of a Cochrane systematic review have revised their conclusions about the relative effectiveness. They now conclude that giving women antagonists leads to similar live birth rates compared with agonists. Previously, they had concluded that women who used antagonists tended to have lower birth rates than those using agonists. And again, if we look at the Cochrane evolution at that time, it is really a pity, because I told you, here in 2002, for clinical pregnancy rate, just borderline statistically significant at that time, live birth rate was not a difference. Then 2006, ongoing pregnancy or live birth rate, just statistically significant. And then eventually Cochrane analyzed on a huge data set, live birth rate per randomized patient, giving you an odds ratio which is exactly the one that we reported in 2006 already, and concluding eventually that no major differences in live birth likelihood between the protocols exist. Hopefully ending a controversy, but this is just to highlight to you that from 2006 to 2011, this was another 6 lost years, in my opinion, of controversy about what would be the more efficacious protocol. I cannot resist the temptation to show you, if we look at the Cochrane database from 2011 and look again at the 5 trials on which the initial conclusion was based, that the clinical pregnancy rate would be lower. The people running Cochrane have changed the data input, because if we look again, this is now clinical pregnancy rate in the 2011 Cochrane database, but only for those studies that they analyzed in 2002. The statistical significance is gone, because they were now choosing the correct denominator, which is per randomized patient and not per protocol. So just as a side note. So let me end this section. The data have always been there. It was just we did not look properly. So let's move on to the next section, which is agonist triggering of final oocyte maturation. In brief, this is something that can only be done in the antagonist protocol, because the pituitary gland is still responsive to an agonist bolus dose. And what happens is, if you give an agonist bolus dose, you have a rapid release of LH from the pituitary gland with a profile which is similar to the one here in red, but which is different from the LH peak profile in a natural cycle. Now, what has been shown by a number of authors is that after such a steep increase and steep decrease, this is enough for the oocytes to take up meiosis and proceed to metaphase 2 of meiosis 1. But this LH peak does not suffice to yield fully functional corporal lutea. And what occurs here is a rapid luteolysis after agonist triggering. Now, the effect of this luteolysis is that after agonist triggering, OHSS appears to be at best, a very, very, very rare phenomenon. Because if we look at the RCTs that we have, we do not see a single OHSS case in any of the GnRH agonist-triggered patients exposed. And we do have a huge data set now on observational studies, more than 1,500 patients, all OHSS risk patients, being triggered with agonist, and only the very odd case of OHSS has ever been reported in some abstracts. So we are now very, very confident that agonist triggering truly prevents OHSS, and is maybe the most effective secondary preventive measure that we have in our hands today for a patient who we identify to be at risk of severe OHSS. Now, the developmental competence of the oocytes after agonist triggering is perfectly okay, which we know very well from oocyte donation studies. We have very good pregnancy rates after agonist triggering, and then, of course, from a huge number of studies on frozen thought cycles. Now, putting this together, we developed a concept in Lübeck as early as 2004. We routinely do antagonist stimulation because we always have the way out, the back door, if a patient hyperresponds. So we define OHSS risk according to some ROC analysis in literature as more than 18 to 20 follicles larger than 10 millimeters on the day on which we want to trigger. Now, in that case, we never give ATG anymore since many years, but we only trigger with agonist. We use 0.2 milligram triptorelin, decapeptyl. We then electively vitrify all 2PN oocytes, and then later in a natural or artificial cycle transfer. Here you see data from a prospective observational study. You see here the time point 0 is the time point when agonist triggering was performed. And then patients, because they typically have many oocytes, will undergo repetitive frozen thought cycles, on average 2.2 in that study population. And you see here the cumulative chance of live birth over time from a single oocyte pickup. Now, I think this is not a miracle thing. You all can do antagonist stimulation, you can all do agonist triggering, you all have a freezing program. And you can offer your patient now, rather than cancel the cycle, rather than doing coasting or other measures, which we are not very confident about the effectiveness really, you can now freeze everything and transfer later in a natural cycle, and this is what you can expect. And of course, the OHSS incidence here was 0, and this is a true risk population. Now, the question is about risk, but the other question is about tolerability. Is it still tolerable to a patient that has 30 or 40 follicles really to undergo oocyte pickup? Or should you not maybe cancel such a patient? We did a tolerability assessment by a visual analog scale in a cohort of patients having more than 20 follicles on the day that we triggered. And you see we asked the patient, so this is 1 is no problem at all, 5 is unbearable problem. And we asked them for headache, nausea, abdominal tension, and abdominal pain 3 to 5 days after triggering. And you see the outcome here, and as a median, it was very well tolerated, so you do see quite a range. And what was astonishing to me is that those patients that had really major problems were not necessarily the patients that had a huge number of follicles. So there's no correlation whatsoever, if that is allowed to say, on such a small cohort. We did a German multicentric study, keeping that brief. So this was really a confirmatory study involving 5 centers, involving different freezing methodologies, involving different cryo cycles, different protocols for the frozen thought transfer, and again, the outcome being very positive in terms of live birth rate and OHSS prevention. So agonist triggering and freeze-all in the OHSS risk patient is, and I'm very confident about this, it is efficacious and it is safe. Also in terms of child health, we also did create some data here. So to our opinion, it is the current best option if hyperresponse occurs. Now, how about agonist triggering and fresh transfer? I think here there's still some controversy. This is a forest plot from a Cochrane analysis that I've also been involved in. And here you see all the RCTs comparing ATG triggering with agonist triggering, and then the studies are stratified by different types of luteal phase support. So up here you see the studies where only progesterone was given for a fresh transfer after agonist triggering. Here, progesterone plus estrogen. Here, bolus doses of agonists in the luteal phase. And here you see the concept of giving very low doses of HCG in the luteal phase. So these are, again, all RCTs. But what is striking to the eye immediately is none of the studies, like all these studies here, are not in favor of agonist triggering and doing a fresh transfer. And even those low-dose HCG studies combined would give you a lower pregnancy rate. Now, if that is a problem or not is maybe in the eye of the beholder. As a effect size, it is between 6 to 8%. And some people claim, well, this is better than maybe freezing and losing some embryos because of freezing. This is maybe better than putting my patient at OHSS risk. So I still have a reasonable chance of pregnancy, but I urge you to really look closer into these data and decide for your freezing efficacy what would be the best option to deal with for the time being. Now, in the last 10 minutes or so, let me share with you some further insights and lessons learned from a huge clinical trial program, which was the program on choreofolitropin alpha called ELONVA. I assume you are all familiar with it because I know in Greece it's licensed and you're using it. Very briefly, this is the protocol on cycle day 2 or 3. ELONVA is injected, which will then act for a full week. It is licensed for use in the antagonist protocol on stimulation day 5, initiation of antagonist. On stimulation day 8, assessment by physician, does the patient need additional FSH, and if so, daily doses of recombinant FSH until predefined HCG criteria have been met. There are 2 doses of ELONVA out there. So one dose, 100 for the lower body weight women and 150 microgram for the higher body weight women. As I told you, a huge trial program, and I'm just wrapping this up in a single slide for you here. So you see here the ENGAGE trial, the largest IVF study that we've ever had on ovarian stimulation, a non-inferiority study by design, showing equivalent pregnancy rate between ELONVA and daily injection of FSH, slightly more oocytes, 1.2 plus. There was the ENSURE trial, also a RCT equivalence by design for the lower body weight women, 100 microgram, only 400 patients, showing more oocytes with ELONVA, so a stronger drive. Then there was the TRUST trial. We will come back to this in a minute. This was an uncontrolled study designed to test for the safety. So there was repetitive administration of the same drug, which is a new hybrid protein, to assess if there's no immunogenicity and no allergic reactions. And then there is a parallel study, which is called the REALIZE study on long agonist stimulation. Very briefly, the outcome of the long agonist study was that there's a very high number of oocytes after ELONVA stimulation. The participant number is very small, only 50 patients. So for the time being, we do not really understand what's going on in terms of pharmacodynamics, ELONVA in a long agonist protocol. So I'd urge you not really to play around with it too much because there's a serious concern for hyperresponse. So I'm going to go through a couple of questions. My first is, are endogenous LH levels and pregnancy likelihood associated? So in my center, we routinely measure hormones during ovarian stimulation, one of which is LH. Now, is that really necessary? You all know that the LH is, during stimulation, suppressed. So the more E2 you have, the more you suppress LH, which with a nadir at the time of embryo transfer. And the question is really, do very low LH levels indicate that maybe the patient would need exogenous LH, or would it indicate that this patient has a poor chance of pregnancy? So what we did was, on a huge data set, we were stratifying the population according to the endogenous LH level on stimulation day 8 and on day of HCG by quartiles. And you see here, this is for the ENGAGE trial, the lower quartile has very low LH levels. And bear in mind that the detection limit is close to 0.5. So this is very close to what you still can measure in your ELISA, very massively suppressed. So this is the cutoff for us to define low and high LH. Now, and if you look at it, this is a univariate analysis from the ENGAGE trial 1,500 patients, central measurement of LH, so very reliable data. You see day 8 and day of ACG, the quartiles of LH, and here in the univariate analysis you see the ongoing pregnancy rate, and you see it is perfectly stable throughout all LH categories. And we took this to the next step, and we did an individual patient meta-analysis, which has just been out now in RBM Online, on 6 trials. And here you see the comparison low LH, lower quartile, and normal and high LH for ongoing pregnancy rate per trial. And we adjusted for trial, for age, and for numbers of oocytes retrieved, which are all significant predictors. And you see here the overall adjusted odds ratio is exactly on the unity, which I believe allows the very confident conclusion that we can close the book on the issue of whether or not endogenous LH tells us anything about pregnancy likelihood. So the answer is there's no association between endogenous LH and pregnancy likelihood, and low LH, therefore immunoreactive LH, I'd like to emphasize, cannot serve as a rationale for LH supplementation in ovarian stimulation. My next question. It has already been touched upon by the previous speakers talking about endometrium and endometrial maturation. What is the incidence and effect of progesterone elevation? Now this is again a combined analysis of antagonist phase 3 trial data and Elonva phase 3 trial data. This is more than 1,700 cycles with a central measurement of hormones. And first of all, what we see, this is data on file. It's unpublished. We've submitted it to ESHRE, so you're really the first people ever to see these data. What you see here is, first of all, the incidence of progesterone elevation, defined as more than 1.5 nanogram per mil, either on day 8, left, or day of ACG, right. And you see it is 3.2 on day 8 and approximately 8.4 on the day of ACG, which is very similar with what has been reported previously. Now, this is the effect of elevated progesterone on day 8 and on day of ACG, stratified by the number of oocytes. And if we look at this panel here, what is really striking to see is that there is a detrimental effect, of course, of elevated progesterone, that it is indeed clinically very relevant, because really here it halves the chance for a patient to become pregnant if progesterone elevation occurs. But what is also interesting is that as the number of oocytes increases, this effect is no longer that prominent. For reasons we do not fully understand, but maybe it is that these high responder patients form better embryos, and that these better embryos can maybe better deal with a imperfect endometrium. We do not know. But what is also striking, of course, is that progesterone elevation depends typically on the ovarian response. That is, the more follicles, the more progesterone. So the patients showing most frequently progesterone elevations are those with a high number of oocytes. And this is why, if you put this all together in a systematic look, if you could prevent progesterone elevation, it would, at the end of the day, not dramatically change your pregnancy rate overall in your study, because those patients that show it most often are not those that really show the drop in pregnancy rate. But bear in mind, we are not treating systems, we are treating individual patients. And as a best estimate, we have to say that if progesterone elevation occurs, this will nearly halve the chance of a pregnancy, of a patient to get pregnant. So I think this is certainly something that we might need to have a closer look and maybe implement into the routine that we do in ovarian stimulation. I'm skipping this for the sake of time. I think I have a couple of more minutes. Another fascinating observation. We all know that some patients, if we have predefined criteria for ACG, are reaching these criteria fast, and some patients it takes longer to reach these criteria. Now, my gut reaction is those patients who take longer, first of all, have a worse chance of pregnancy, and maybe those patients who are older have a poorer prognosis. Some doctors would say, no, those patients that are very fast are those that are older because they have an accelerated growth of follicles. So we had a closer look, and we had a beautiful data set here again from the choreofolitropin studies, because we had 1/3 of the patients reaching HCG criteria very early, as early as stimulation day 6, 7, or 8. Now, first of all, the characteristics of the patients. Early responders, late responders, the threshold being 8 days. And you see here age similar, body mass index similar, median FSH perfectly stable between these groups. AFC perfectly similar. So there is no morphometric characteristic that you can say, well, you are going to take long, and for you it's going to be a fast stimulation. In terms of follicular growth dynamics, it is also fascinating that, of course, on day 8, the early responders had more follicles. This is why they're early responders, of course. The late responders are lagging behind, but on the day of HCG, they caught up. So if we look at the number of oocytes that were eventually available in the early versus late responders, it was perfectly stable. S was the number of good quality embryos. Number of embryos transferred, very similar, 1.7, maybe slightly less here. And the pregnancy rate was 44 versus 37%. Now, this is not statistically significant. This is maybe a statistical difference. This is, to me, most likely a small but clinically relevant difference. But it is not really that the response rate or the speed of response tells you a lot about the outcome. So, the answer to the question is there are patients with a faster response, but the number of oocytes is similar between fast and slow response patients, and a short follicular phase does not compromise the outcome. I'm skipping this, although I think it would be very fascinating data for the sake of time. And I'll share with you something, again, data on file have never been shown from the TRUST trial. My center participated in the TRUST trial, and again, this was a trial where women underwent one choreofolitropin cycle, and if they failed, no dropout, another one and another one. So 3 cycles in exactly the same protocol within a short time frame. And I immediately looked at the study protocol and said, wow, this is beautiful, because now for the first time on a sufficiently large sample, we can understand what is the natural variation in response of the same patient to exactly the same protocol within a short time frame. And this tells us a lot about the background noise that we have in ovarian stimulation, because we all do a lot of dose adaptations, we all use prediction studies, modeling body weight AFC, and we give this dose and that dose because we want to have 12 oocytes or 8 oocytes, and the next one wants to have 15 oocytes, but we do all this without understanding what is the background, what is the basis on which we do this. And the basis is how much natural variation is there in response to the same protocol in the same woman. We do have these data. If we look at it systematically, we see cycle 1 was started by 700 patients approximately, and then of course we have patients dropping out, patients getting pregnant. So we have approximately 200 patients receiving 3 times the same protocol. Systematically, the mean number of oocytes, of course, is perfectly stable. We knew this from many studies, so it is not that you decrease the number of oocytes if you do repetitive cycles. But we're interested at the individual level. Now, this looks very busy, but if we look from a first to a second cycle, this is the percentage of patients that yielded exactly the same number of follicles. We also did this for the oocyte, it's exactly the same. The same number of follicles. And then you see here the deviation in number of follicles from a first to a second cycle. And you see this enormous spread. Wrapping that up, this is approximately 30% of patients had a decrease of at least 3 follicles, some even 10 follicles or more. And 24% had an increase of at least 3 follicles, and some 7, 8, 9, 10 follicles. Same protocol, same woman. Short time frame. So we're going to look at it at greater detail at ESHRE, so please have a look at it, but just to give you a glimpse at the data, 1/3 of patients switched from a normal ovarian response, defined by quartile analysis again, this is the interquartile range, is 10 to 18 follicles, to a low by quartile, which is 0 to 10, or high, which is more than 18, 1/3 switch between one cycle to the other cycle. So the odds ratio for a normal responder to show a low or high ovarian response in the next cycle was 0.45 from the first to second, and 0.56 from the second to third cycle. So that is, to me, substantial. And it does have very far-reaching implications, say, for all the prediction studies that we have done so far and that we were frustrated to see them fail. Do you give me another 3 or 4 minutes? 3 minutes, okay. So let me just touch upon the issue because it's very practically relevant. I see there's many embryologists in the lab. My embryologists always tell me we don't want to work on weekends. Okay? Please, no oocyte pickups, no teaser patients on weekends and so on. So how can we avoid weekends? By scheduling the initiation of stimulation. Now this is how it works. In the agonist protocol, it's clear. In the antagonist protocol, most studies have done oral contraceptive pill pretreatment. You set the patient on the pill. You tell the patient, stop now. Within a pill-free interval of 2 to 5 days, you tell the patient, now you start, and then we will have the oocyte pickup during the week and not on the weekend, hopefully. Let's have a look. So we did a systematic review, looked at all the pill treatment studies, and we've seen as an effect, if you do pill treatment, you need more gonadotropins, on average 360 units plus. You need more duration of stimulation, on average 1.3 days plus. What you do not get, and this was another theory of pill pretreatment, you cannot synchronize your cohort and get more oocytes. Because this here is what you see, especially the large studies did not show an additional oocyte. So the mean effect size is 0.6 oocytes, which is in clinical terms nothing, of course. So the concept of follicular synchronization has failed, to my understanding. And what is highly fascinating is if we combine the studies for ongoing pregnancy rate per randomized patient, you see, if you look at the panel here, these are the normal responder patients, you have -6% in ongoing pregnancy rate after pill pretreatment. We do not have the time to discuss why, but I think maybe in the next coffee break, those of you who are interested, we can. So you do have a statistically significant decrease in pregnancy rate. Now, may I ask you, ladies and gentlemen, did we need all these studies when it comes to avoiding weekends? I don't think so, because on a rational basis, think about it, if you use predefined criteria for HCG, we know from a large number of studies that there's such a huge variation, here comes variation again, in the duration of stimulation. It was 6 to 15 days in the Lonva study. It was 6 to 18 days in the phase 3 antagonist studies. It's been 7 to 16 days in the Middle East trial, many other long agonist studies. So how on earth, if you use predefined criteria for HCG, how can you determine when the oocyte pickup is going to happen by determining when you start the patient? I fail to understand the concept totally. And pre-treatment does not decrease the variation in the duration of stimulation, because if we look back at this slide here, duration of stimulation, if you look at the standard deviations with pill or without the pill, it is exactly the same. So there's not much to be gained here. And the same is, of course, also true for the later data on pre-treatment with estradiol. So some author says, well, yeah, this is the pill, and pill is not good, and gestagen and bad pregnancy rate, now we use natural estrogen. But when it comes to avoiding weekends, also with estrogen, it is just not a rational approach. And if you want to avoid weekends, I think what we should do is we should just play around with the HCG criteria, not going to the extreme. But this is a study from Tremellen from Australia, a retrospective cohort study. This center said, maybe the embryologists went on strike, they said, we're not working on weekends anymore, stop it. So they said, those patients that we would do the pickup on a Saturday, we move them to Friday, so we take them a bit earlier, and those that we would do on a Sunday, we move them to a Monday, okay? So there's not postponing one patient for 2 days. And you see here the live birth rate for Tuesday, Wednesday, Thursday, no playing around with the HCG criteria, and those on Friday and Monday were some earlier, some later, and you see the live birth rate perfectly stable. There's also in the paper a sub-analysis for those patients that have been put earlier and those later, and again, it's perfectly stable. So we can play around with the HCG criteria, and this is also what we've seen in the ENGAGE treatment, in the ENGAGE trial, where it was allowed to postpone for 24 hours the HCG. And I'm skipping now growth hormone because time does not allow. There's many new things out there, which I do not have the time to speak about it. One of the most recent that has just finished phase 1 is the FSH GEX. Anyone heard of it? It's a new FSH molecule which is produced in a human cell line. And it is quite different from the recombinant, of course, in terms of glycosylation, in terms of antennaarity. It is different in terms of pharmacokinetics, it is different in pharmacodynamics, It is also different from the urinary, because what is in the urine in terms of glycosylation is different from what is in the bloodstream because of renal excretion. So phase 1 has been done here. I've seen the data. It's very interesting, and I'm sure FSH GAGs will be around. So let me conclude. Last 10 seconds. Continuous efforts have been made to make COS more efficacious, but I've put a question mark here because I think we've really reached the plateau where we understand that by playing around with our ovarian stimulation protocols, there's not so much to gain. And I was delighted to see that my previous speakers have really clearly highlighted to us that most of the innovation in IVF will come from technology and the IVF lab, I believe. But what we as physicians need to do is we need to make it simpler, we need to make it safer, we need to make it better tolerable to our patients. Thank you very much.